this is actually not my work medically, but it's just the enthusiasm and something that we should be doing, and which I was instrumental in pushing, because I got a call from somebody at 7:30 in the morning who generally I dread taking his calls. And then it got even worse as we went on, because he called to say that his father-in-law had a stroke at 7:30 in the morning. Dr. Kopika knows who I'm talking about, and she was also on tenterhooks with that. He called to say that his father-in-law, who's 87 years old, has atrial fibrillation, or is on anticoagulation, has had a stroke. So he very intelligently told me also that let's get a CT done fast, because he's bled. So, So he was an 87-year-old, and he got up, waking, and with a dense left-sided hemiplegia, grade 0, history of atrial fibrillation on anticoagulation, then stroke. So, of course, we got the CT done, just as you can see, a plain CT, one image, no hemorrhage, nothing on this. So since there was no hemorrhage, obviously we needed to think of a stroke. So we got a diffusion MRI done, which didn't show anything. And he had a dense hemiplegia, so that was perplexing. So we did the angio. And on the angio, what we saw, top angio, non-contrast angio, we saw that there was a total, Yeah, this is an MRI angio. So because there was no hemorrhage, a stroke could not be seen on a CT. So we need to take the patient to MR and look for diffusion restriction, which is the earliest sign. In this case, there was no diffusion restriction also. So since there was no diffusion restriction, it was confusing. So we took him across to, then we did an MR angio, which is something which is usually not done. Most neurologists just ask for diffusion. But we did that because we found a total occlusion to the MCA. So the right MCA was totally occluded. And also what we noticed, we could not see the left internal carotid artery. Here's the right internal carotid artery. That's the basilar and the posterior cerebral. And we couldn't see that. Of course, the middle cerebral on the other side was coming from the opposite anterior circulation. So, and that is the neck angio. So we did a neck angio. And the neck angio shows you a very tight stenosis of the left ICA here and a thin streak of left ICA going up. This was a contrast angio, and that's how we were able to see that thin streak. So he had a right MCA occlusion, and he had a tight stenosis of the left ICA. Yeah, two things. So we took him up for thrombolysis immediately. Okay. Of course, everybody kept saying that he's 87, he's 87, he's 87. But I think I want to show this case because age is only a number. I think we should not, people didn't want to treat it because of that reason. And so if you see here, here's the angio. This is the right carotid angiogram here, and you can see a total occlusion of the right middle cerebral artery out here. So the interventional neurologist went in, and he put in a wire, and he sucked the clot out. While he was sucking the clot out, we noticed the man had developed another clot in the left MCA out here. The left MCA had got occluded. So he sucked that clot out, So he sucked the clot out, and the right MCA opened up beautifully. That's the injection. And when attacked this and sucked this clot out, going across the ACOM. Then we started to look at the left ICA, left internal carotid artery. And you can see here that it's a very tight stenosis out here and very thin vessel going up. Very, very thin vessel going up. A very poor circulation there. And of course on table we found that he had also developed a he was quadriplegic because this area had got affected. So he tried to start looking at what to do with this left ICA. He dilated it and, went ahead. So he dilated it, and while he dilated it, and even after dilating it, it started to close down further. Okay, it started and got totally, as good as totally occluded. So then the next step was only to stent, and so that's when he stented the left ICA out here.
Is it a bare stent or a covered stent?
It was a covered stent. And so Here you can see this is the angio done, which is showing a pretty good circulation, and the left-sided circulation is good. We did a CT post-procedure. Of course, patient was quadriplegic and slowly started to improve over the next few days. But of course, we did a CT to check for any reperfusion hemorrhage. There was a small area of reperfusion hemorrhage, nothing dramatic. The rest was fine. We did diffusion MRI, which showed he had just some very tiny infarcts, but no major infarct at all. Brain parenchyma preserved. And that's just a T2 weighted image. And this is his MR angio, I think about a week later, where you can see the full circulation is fully restored. Beautiful circulation, which looks as good as absolutely normal, except for some mild narrowing out here. Absolutely normal. Sorry. And this is a comparison of when he came in, what he had, occlusion of the MCA, left ICA, dense hemiplegia, then developed a dense hemiplegia on the other side also during procedure, and that's finally after he was revascularized and now doing very well. And brain parenchyma preserved. There's one more, Nishant, you want to say? One more small one. Just
yeah. I will just brief the new technique for ischemic stroke, that is mechanical thrombolysis. And these are the global body next. This is situation. A 39-year-old smoker, chain smoker, had right dense hemiplegia and aphasia. Next. So CT showing old ischemic change in basal ganglia. Next, please, it will show. And here we found a occlusion of M2 segment of left MCA, dominant hemisphere. Next. Next. So again, same technique. I went across the thrombus, checked the circulation. This you can see the patent middle cerebral artery distally. Next. Next. Video is not working. That's fine. So now you can see full patency of middle cerebral artery distally with just intrathrombus RTP injection, 4 mg RTP injection. Why I didn't use a mechanical thrombolysis is just because the thrombus node was small. Next case will be the thrombus extraction. So he completely recovered. Go next. This is the 7 MRI angiography, full patency of MCA. All 3 terms are patent. Again, these are the evolution stages of new mechanical thrombolysis. Again, 3 hours onset and a dense MCA sign for a 69-year-old atrial fibrillation patient. Dense MCA next. And you can see a thrombus into middle cerebral artery, M1 segment. Next. Same story, 69-year-old and having occlusion of middle cerebral artery distal to temporal branch. Next. Same thing, this time I use a mechanical clot retrieval because thrombus node is large, patient is having a sclerotic artery, so they are having more chances of re-occlusion post typical thrombectomy. So I choose the stent retriever, pass beyond the thrombus. Next. And this is at the time of the deployment of stent retriever. You can see the restoration of perfusion to the left hemisphere. Next. And you can see the markers of the stent retriever. Next. And this is the plot I extracted from the circulation. It's quite large plot from the M2 segment to M3 segment of middle cerebral artery. Next. Video is not working. Next. 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 Yeah. So now you can see, although there is sluggish flow into MCA, this will taken care because the flow is the best thrombolytics. Body takes care. So just opening the proximal trunk and leaving, not changing the distal cortical thrombosis is the best option for these older patients. I mean, just a number. Next. Extubated on day 3, absolutely fine, mild slurring of speech, and on MR and MRA day 5, minor changes of the ischemic changes, no permanent damage. Next. And this is, you can see, complete opening of the MCA with all 3 trunks taken. Next.
Thank you very much.
This snippet in reference to Shanti. I'm going to speak a little about the Mayo Clinic. I'm going to speak a little about the Mayo Clinic. As you know, it was founded by the father, William Mayo, and his 2 sons, William and Charles Mayo. They were practicing in Rochester in the 19th century and the early part of the 20th century. And in those days they used to practice either at home, in their clinics, or at the patient's home. Because hospitals were to be avoided. As you know, in our earlier snippets, I told you the tremendous number of deaths that used to occur in hospitals in those days, pre-anesthetic days, and pre-asepsis and pre-antiseptic days. So these two young doctors were once driving their buggy with a horse to a butcher. I don't know if you know the story. Well, I'll tell you the story because it's interesting. Why were they doing that? They were wanting to have a sheep's head. And why did they want a sheep's head? They wanted to practice enucleation of the eye because the next day they were planning to remove the eye of a patient who they thought had a tumor within the eye. But as they went to the butcher's shop, the butcher was leaving and said, "You better go away, and I warn you, don't stay here. It's going to be a big storm. Please go home quickly." So they drove their buggy home and they had to cross a river there, and they just crossed the river when the storm broke, and the storm broke with such fury. There are hurricanes there in America sometimes, that they just crossed the bridge and the whole bridge collapsed, and they saw that the houses were being blown apart and the debris damaged their buggy and broke their buggy. The horse went away and they were literally being blown away with the hurricane. They took refuge in a blacksmith's house. They found the horse, fortunately, caught hold of the horse, and when the storm ultimately subsided, they were planning to go back home. Until when they came out, they saw the tremendous destruction that had taken place, and they decided to go back into town. Many had died, many were badly injured. The old man, the father, had gone to a hotel where many injured people were taken, and Charles and William Mayo went to the convent of St. Francis, the Charity Sisters of St. Francis. Many people injured there, and there their mothers and daughters were nursing them, and they worked all through the night, all through the day, and all through the next day, trying to help them. And they asked the Mother Superior, her name was Mother Superior Alfred, requested her to get the sisters who could help them with their nursing work. The sisters were on vacation, but she obliged, and the sisters came and helped. Now it's interesting that just before this happened, the bishop of that place had suggested to the Mother Superior, should not Rochester have a hospital? And the sister replied, no use, because people hate hospitals, people die in hospitals, they are treated in doctors' clinics or in their own homes. But when the Mother Superior saw the tremendous amount of death and disease and damage and trauma after this tremendous hurricane, she again agreed that yes, maybe we should have a hospital here. So they asked the father, William Mayo, shall we have a hospital here? So he says, no, people don't like hospitals, there's no use having a hospital, nobody goes to it. But she persisted and persisted. So the old man said, all right, we'll do that, but you get the land and you find the finance for the hospital. So these Sisters of Charity in St. Francis Convent worked hard, got the money, and got $2,200 for the land of St. Mary's Hospital. And the Mayo brothers and the father went all over America to find plans for the best possible way to build the hospital, and submitted the plans, and ultimately the hospital took place. That's how St. Mary's Hospital was founded. But then, this was a Catholic convent of St. Francis was Catholic. The Protestants didn't like that. They said, we won't come to our Catholic institute. And some of the friends of Dr. Mayo said, I'm sure this is going to be a big fiasco, so we are not going to patronize it. And also, an important rich doctor of a rich Catholic family had been excluded from all this. So, the Catholics also were not very much in favor of it. So it was difficult to find patients getting into Mayo at this point in time. And finally, the worst thing that happened was, all the sisters of St. Francis who were willing to nurse said that no, we would rather go back to our own teaching profession. They were in the teaching profession. They knew nothing of the nursing profession. And that is when a great blow was struck when the father, who had actually mooted the point of having a hospital here, decided to remove the sister from her post. At which point in time, this sister came over to St. Mary's and took over as a nursing chief in charge and the administrator in charge. And things went on very well for some time. She trained a junior, a lady called Sister Joseph, who was an immense help to Mayo, and she was there for a very long time. And that's how Mayo progressed. And the last hitch was when a doctor opened a homeopathic hospital next to St. Mary's. Do you know that? It was called the Riverside Hospital. You know that? Well, it was called the Riverside Hospital, and that again made a dent on patients going there. But fortunately, the doctor closed down the hospital, and from that time on, Mayo prospered. With two great people, William and Charles Mayo, William was the elder, Charles was the younger. This is what William said of Charles. William was the elder, that my brother is a far better surgeon than I am, and he's pushed me down to the belly, which means that Charles did all surgery except the abdomen, whereas William only operated on the abdomen. And when somebody went to write down their biography, this is what the Mayo brothers said. We were not magicians, we were not extraordinary persons, we just had remarkable opportunities at a particular time and a particular place with some inbuilt help which you can never get at that time or ever. Of course, it was not quite right, but this is what he made of it. And it's interesting to see what sort of a humanitarian people they were also. The story is that William Mayo was once given a patient who was poor and who couldn't afford it. So he then goes up to the man and says, he was about a 21-year-old man, young man, this operation will cost you $100. So the man replied, but I have none. Oh, well then, I'll do the operation, but when you get well, you get back to work and pay me $10. All right.